even if I look at this national platform, percent of specialist consultations go to the wrong specialty. When you see this kind of pattern, high volume but questionable quality, what could be the potential root causes?
Yeah, I'll say you're talking about a large-scale problem because of numbers, but this is not an uncommon.
Are we accidentally building systems that widen the health disparities rather than close them?
We are building the healthcare systems that we already have. We're exposing a lot of the inequity that has been there and been part of it. But now that you have to think through digital medicine and where people are,
right,
it's much more obvious what's happening.
Welcome back to Spark and the Forge podcast. I'm Subrata Kar, and this is where we unpack the boldest shift in tech systems and outcomes with data that matters. We have scaled telehealth, but are we really improving care? You see, the numbers are staggering. E66, which is India's national free-to-use telemedicine services, has logged 344 million teleconsultations. But here is what those impressive numbers hide. Recent frontline analysis reveals only 20% of E66 referrals reach the right specialist. We now have proof of systemic dysfunction. 65% of the specialist consultations are sent to wrong specialty entirely. Access gaps persist across the demographics, and quality varies widely from system to system. We have mastered the technology of connections, but not the science of care delivery. And to explore this paradox, I have invited someone who's seen telehealth from every angle: emergency rooms to policy tables, startup boards to global health systems. Dr. Aditi Joshi, emergency physician, global consultant, and co-creator of the Telehealth Success Framework. And now, let's get started. Dr. Joshi, this episode is called Redefining the Telehealth because the very definition of what we are building has evolved quite dramatically. So let's start with the basics. People hear the word telehealth, they often think about it's a Zoom call with a doctor. What does telehealth actually encompass in 2025? And what's the difference between telemedicine and the telehealth, if you would like to explain that? And how should healthcare leaders be thinking about it differently than what they did 5 years ago?
So I'll take your first question. I'll do that one first. It is a very common question. How do you define this? Because there's a lot of confusion about it, and it limits how people actually use telemedicine or telehealth. So firstly, telehealth is just using technology to have a medical encounter between two parties. And so there's two different ways that I define it. So the first way is by the technology we're using. So as you mentioned, the first is video, which is what's most commonly people think of, is seeing somebody on video and having a medical visit. The other types, though, are actually phone calls, which technically are the most common one by numbers. It's most people have telemedicine visits by phone calls. And then the third, which is becoming much more prominent, is chat. And this can be meaning that you fill out a survey, then have a provider take a look at it later, or it could also be chatting with AI. It can be triage at chat, it can be asynchronous, but this is basically having a chat version instead of speaking real time with somebody. Then the second group is basically who are the two parties on either end. So the first and most common that people think of is the patient and the provider. And so this is what most people think. They have a call scheduled with their doctor, or they need to see someone, and so they reach out, register for a telemedicine visit, and then have a visit. So that's one. And then the second is provider to provider. And so this actually has been around even longer. So the way that you can think of it, so in the US, we have a very old program called Telestroke. And so you can imagine it this way. There's an ER in a rural area, and if a patient comes in with a stroke and there are no specialists in that region, that hospital, that can see them, neurologists, et cetera, what they'll do is that over telemedicine, they will actually, over video, most of the time over video, speak to the neurologist or the neurosurgeon and have a discussion about what to do with the patient. the neurologist on the other end can also see the patient while the doctor is in the room with them, the ER doctor in this case, and then they can make it the right plan for the patient going forward. And so that is in general what the types of telemedicine are. And then the second aspect of another common question is what is the difference between saying telehealth or telemedicine? And so telemedicine is a bit more restricted. It basically means the actual medical encounter. So all of the definitions of the things that I just described, those would be telemedicine encounters. And then telehealth is much more broad based. So you can consider that if you are going to build out this type of care, you're going to need a lot of other parts of that infrastructure. So it's the regulations, the laws that are needed. How do you pay for it? What technology is required? Who needs to be involved? The leadership, all the other parts that are needed to actually build out these programs are included in that definition. And so I usually use telehealth much more commonly because it is more broad based, but people will understand you in the field depending on how you
Right.
say it.
So now with that broader definition, let's look at the strategic choices the health systems are making. While some countries have mixed models, there are also two dominant approaches that represent the fundamental divide in how nations scale telehealth. So there is this centralized government-led model. India happens to be one. India has e-Sanjeevani, which is a national free teleconsultation model. 344 million consultations have already happened, and it is directly funded by the government. And that eliminates the billing complexity entirely. Then we have this market-driven competitive model, like US, for example. The approach where platforms like Teladoc and Amwell and Doxy.me, etc., and compete for market share with more complex reimbursement across Medicare's, I understand it is 250 plus codes. So while we see innovation through competition, but there is also policy instability in the US, right? Because telehealth rules constantly change at federal and state levels, and doctors often can't treat patients across different state lines. So, Dr. Joshi, you have consulted extensively in the US healthcare organizations implementing telehealth. What specific challenges do you consistently see them facing with this market driven approach? And what makes telehealth implementation particularly complex in the US system, for example?
It's a great question. And I'll say the first thing I want to bring up when you were comparing even India versus the US and the examples you were giving is that telehealth is not actually going to be much different. And it's going to be driven by the way that the health systems and the governments pay for healthcare in those countries. It's not going to be any different. It is going to be beholden to those particular beliefs and then the particular systems and how they hold up. And so the examples you're giving are available in India because there was a government funded and driven
Yep.
program to be able to make that happen. And yes, the US is actually very complex. And what's interesting about the US is that if you look at all of the different types of health systems out in the world, we actually have examples of each one of them. But, I'll start just saying when you're talking about, it's complicated because there are federal programs, state programs. But in general, and for those who may not realize, so federal programs will supersede state programs. So if a federal law comes through, then all states are actually having to do and be able to, are beholden and have to do that first. But then often the federal government gives the states the ability to decide what they want to do in certain circumstances. So in the case of telehealth, for example, so CMS is our big government agency that covers Medicare and Medicaid. Medicare is generally for citizens over 65 who are retired and certain other groups that may need extra care. And then Medicaid generally are for their programs for people who may make under a certain income or have other types of needs. And then also children are covered based on that as well. So if you look at the way that the government set up the telehealth reimbursement in the country, Medicare has certain ways that it's paid for. And so Medicare is a federal law, it's federally funded. And so the states will pay for that in each state, depending on how their Medicare works, but they are going to be paying for it based on what those federal laws are. Then during the pandemic, there were a lot of states that We're also then giving, well, let me back up. So, during the pandemic, a lot of these federal laws came into place. And so then after the fact, though, as the pandemic died down and there were discussions of how do you actually make this reimbursement much more long term, some of these types of reimbursements for telehealth, Medicaid specifically, were actually given back to the states to decide how they want to use this. I give this long list because it really defines how complicated things can get when you're trying to implement something that
Right.
really
Right.
helps everybody, right? It improves access, people can access it everywhere, etc. Unlike India, we generally have one language. For those who don't speak English as a first language, we are required to find someone to interpret. So all of these things are part of it, but it makes it a little bit more.
Even from policy changes, correct me if I'm wrong, currently I think it is about till September 30th for certain categories of health being covered by telehealth. Is that correct?
It is, but I will say that
Mm.
these flexibilities keep on being extended.
Yeah,
Unlike a lot of the policy instability that you were referencing,
yeah,
telehealth
yeah.
actually has broad support and has support by both parties. So it has continuously been passed
Mm.
for these laws to continue for reimbursement. It has
Yeah,
changed in certain ways, but with a lot of the advocacy that happens by some of the big
yeah,
specialty organizations, this also makes a big difference. But that in
yeah,
itself, right? So that's the
yeah,
government fund. But you were actually
yeah,
asking about the market driven forces, which
yeah.
also created quite a big market for the way that
Mm.
telehealth works. And I will say that when I started in telemedicine 12 years ago,
Mm.
it was mostly market driven that brought it to the place that it is now. Private companies that were building telehealth platforms and offering services to patients. That's how it started, and then it got much bigger during the pandemic, of course. But what we're seeing now, and I think this is what's interesting, that changed right over the last
Mm.
5 years, is that a lot of the offers that are now being made are basically direct to consumer, and
Mm.
that market has almost exploded. So you're going to see people selling services for all the types of care that they give
Yeah,
in person, and now they're selling it over telehealth, which
got it.
is fine, of course, but obviously it is making it a lot harder to regulate, and it also makes it harder to make a federally funded large program when a lot of people are just going through the private market.
You know, this is what concerns me when I look at this number 344 million plus tele consultations in India, because there are situations where frontline specialists report that only 20% of referrals are actually appropriate for their specialty. Volumetrics can mask the massive amount of quality gaps. And that's the measurement challenge takes us directly to your framework, Dr. Joshi, because you didn't just identify the problem of inconsistent success metrics, you actually built a solution. So, coming up next, the Telehealth Success Framework, the 5 pillars, how organizations implement it, and what it reveals about the sustainable virtual care program. So now let's move to what every healthcare leader really wants to know. How do we really measure whether telehealth is working? Because scaling without reliable metrics isn't just a progress, it's expensive guesswork. That's where your telehealth success framework, in my mind, comes in. And so walk us through those 5 pillars, and what gaps in traditional measurement made this framework so necessary.
Right. Yeah. Thank you for bringing that up. So, this framework I actually co created with my co author of the book that we outlined, the Telehealth Success Framework. But basically, when we were talking about it, we are thinking, okay, what have we done in the past that allowed for these programs to be successful? Now, just in my, of course, history, I've built 13 programs, and not all of them were successful in the beginning or were successful overall. And so, there's lessons in all of that. But I'll go through quickly the five
Yeah,
pillars and why
quickly.
each of
Yeah.
them are important. So the first is patient success. And, to your question about how do you make sure that it's working? I mean, the biggest thing you have to know is your patient population, who you're serving, and what you're doing. We can talk about that, even if we're going to compare India and the US, there are
Mm.
things that are very different about India and the US, and there are things that are actually very similar, right? There are
Yeah.
access gaps, connectivity,
Yeah.
you have that issue. But of course, the languages are going to be much, much different in India than in the US.
Yeah.
So you can compare it that way. But really, so
Yeah.
the question is, how do you make sure to do that?
Right.
Second is the clinician success. And this I always find probably most dear to my heart, mainly because when I think about, and most dear to my heart, I mean just because I had to do it personally, being a doctor myself, and
Mm,
having to convince my colleagues of why this was safe. How do you
mm,
develop quality care, like you were bringing up? And how do we make sure that the ways and the methods and the regulations that we have in place for in person care actually
mm,
translates into clinicians?
mm,
And so a lot of the easy question to your question about the quality is training. And I'll say that's partially true, but it has a full, larger answer to that than just that. And it really dives deep into how do you scale the clinician workforce to use digital tools of the future. But that's a subject probably for another podcast itself. But the one thing I want to add about that is it's really also about leadership and who is a right leader to do this and what kinds of leaders have to be in place to actually be able to build and do this for you. The third is technology. You have to pick it, you have to have the right one. And we both, I'll say that in general, it has to be the most simple one. It is I have been pitched many, many types of products in the last few years. And of course, I'll say that the ones that work the most are the ones that people can use easily and have the bare minimum for what people are trying to build. Fourth is reimbursement. We just talked about that. How do you reimburse it? Because without that, it's almost impossible to scale anything. And so, like you said, you're going to just have expensive guesswork because you're not going to be able to build it out. And you're not
yep.
going to be able to show if the economy is building, is a health care system actually helping patients overall, if you can't actually look and see if it's paid for. And then last is compliance, which is a bit of a catch all term, but what it really means is what are the laws and regulations? How do you avoid fraud? What is malpractice? That's a big deal in the US. I know it is in other countries as well, but really, how do you make sure that you are legally protected on all fronts? All the things that you need to do to make sure that the program itself is compliant with the regulations. And so
Right.
that's the way we built it out and thought
Right.
about it for
Correct.
all
Right.
programs that need implemented.
Got it. So now keeping that framework in mind, Dr. Joshi, when I look at, what's happening, for example, in India, even if I look at this national platform, percent of specialist consultations go to the wrong specialty. With some requests just saying pain because the notes are not properly taken or headache. And so when you see this kind of pattern, high volume, but questionable quality, what are typically the root causes that your framework would reveal? What could be the potential root causes that you see?
Yeah, and this, I'll say you're talking about a large scale problem
Yeah.
because of numbers, but this is not an uncommon problem.
Okay.
So it's really actually basically it's going to be the basic things.
Mm.
But basically, I would want to know why is that happening. So how is this
Yeah.
program set up? How are people getting referrals, and how are they ending up at a certain specialties, right? Because there is going to be a way to fix that. So let's say you're asking for various potential reasons. It could be that the patients are self selecting for a specialist, and patients may not have or exactly know which is a right specialist for them, right? Because obviously there is health literacy that is involved in this. And there are some complaints that could be a number of different reasons. And so it may just be that it's going to the wrong specialist because it's patient self selecting. And there are obviously solutions to that. Second, are there incentives for patients or certain doctors to try to see more of that, or are there certain incentives that are making this happen? I'm not going to blame a group or say that it's like necessarily nefarious, but it could be that there's something incentivizing them to go to a certain area, maybe because they're mostly primary care, and so we think that they need mostly primary care. But let's say that in a certain area, maybe actually people need somebody who is more infectious disease, but it's just not being recognized as where patients need to go, right? So, like, what are the mechanisms that are happening? And, even in a general sense, look at the program and see what are you trying to solve, right? Is this an access program? Is this just because there is a lack of primary care and so you're trying to get patients seen? Is it because you're trying to get patients into certain health systems? You want to find that out too, because based in that, you're going to have to figure out what the problem is, and then you're going to have to actually just create a different pathway to actually solve the problem that you have. But I
Got
promise
it.
you, this is easily solvable. And then, of course, we're talking about training. So that can do that. There can be patient education. There can be information on the website that can help with this. And I don't know this program in depth, and they might have done all of this, right? But if this problem is still happening, there is a reason for it, and there is a solution.
Got it. Okay. So I'm sure your framework have been implemented in different areas in your work globally. So can you share any specific example where your framework really helped the healthcare organization discover that what looked successful on paper was actually creating problems they hadn't recognized?
I'll give you a really classic example that I give just out of our ER triage. And I'll say that this framework was really not built by then, but it was how I built all my programs without realizing it. So it really was part
Mm,
of this. But it is like you said, sometimes you don't actually know the problem you're solving. And so I like to use this example just to highlight this. So
well,
when I was in Philadelphia, the
mm,
ERs and the ERs, probably all over the world, we have a problem with getting people through. They can be overburdened. And we just don't get to see people in a timely manner often because it's too busy. And so, one of the solutions that has been used in the US is basically putting a physician in the triage room. So, they'll see the patient with the nurse and they will write orders for the patient. So, the orders get
mm,
started right after triage. And
mm,
so, by the time they see the ER doctor, after what might be a few hours wait, often a lot of their orders are done. So in our ER, we had started that program, but we decided let's try and see if we can use telemedicine instead.
mm,
Because we were having a doctor in triage. Honestly, it's not really efficient. You actually want the
mm,
doctor in person to be in the ER seeing patients. So we tried it with our emergency room doctor who was in telemedicine. And
mm,
the reason we tried this was because in our national goals and metrics, you must see patients in the ER under 18 minutes
mm,
so that you can actually get it started. And we were not meeting those metrics.
mm,
And so we decided to try this out. And so we did over telemedicine with that particular hospital. And I will tell you, we changed it overnight. So overnight, even though we were only there for 7 hours, it improved it. What our goal though was not only to get the patient seen faster, we were trying to get patients out of the ER faster. We assumed it
mm,
would, but I will tell you that it didn't do that. It got people into the ER faster, it got their orders done faster, but we didn't
mm,
see an actual improvement in our discharge, despite the fact that we were using this more efficient manner. So I bring this up to say that you can try anything out, and you can even have uh, like taking the framework and our idea and say, here's what we're trying to do, here's what we're trying to fix. This should be the outcomes. You can't
mm,
always predict all of it, but we did find that there were other benefits to it, so that was okay. But it was
mm,
interesting finding that it didn't work for everything and for all the things that we had predicted should happen with it. So I'll say in that way that it doesn't always work. And
mm,
we were surprised by that finding, but then it just supported the evidence of the other reasons that the ER gets really burdened up. And so when I
mm,
think about like your question about like how does this framework actually develop it, it gives you
mm,
the right way to
mm.
organize your thoughts, the right way to get the feedback, and to understand where you may need to change by being able to look at it in different silos and say, okay, but where is this problem coming from? So let's fix it in that manner.
I saw your recent LinkedIn post where you argue, I'm quoting, if you are designing for reimbursement, you are not designing for care. And then you extend this to say AI, saying we keep trying to reward digital transformation with analog incentives. Can you explain what you mean by this disconnect?
Absolutely. So AI is an interesting one, right? So you were asking me about the difference in virtual care now versus 5 years ago. So in 2025, the way that I see telemedicine is the backbone and the basics of how you're going to be able to have digital medicine part of the healthcare system. It is just
Hmm,
the basic. How do you connect with technology, right? And now that we have AI at our fingertips, we are seeing the same cycles that I have seen about discussions about how do you
hmm,
implement it, how do you pay for it, how are we
hmm,
going to make quality care, how do we make it safe. The exact questions that I heard over and over and over the last 12 years are happening about AI. And so when
hmm,
I was thinking about, And this particular blog came out of just seeing that pattern and thinking,
And
what is it?
you
Mhm.
referred in the US context, correct?
I'm referring to the US context,
Yeah,
yes.
got it. Yeah,
Because I'm
got
recognizing that other countries have gone about it differently or they're in a
it.
different
Exactly.
timeline,
Mm,
etc. So yeah, I'm talking about the US context. But
yeah.
when we in general are trying to, in this particular way, like reimbursements
Mm,
specifically, we're ending up doing the same thing, and I'm worried we're going to have the same problem again. In that reimbursement is going to create products that people can't really use very well because they're actually going to try to build it around what they think reimbursement will happen. And the reason I say that is because, and that's what I mean by the analog incentives, it's like what they think that reimbursement is
mm,
happening. Because right now we are still building out those
mm,
AI reimbursement codes. There's about two that exist, but again, they're very specific and niche. And so whoever is building is basically thinking, what is going to be the way that we pay for AI? And it's an interesting question too, because at the
mm,
moment, the way that we actually pay for clinical care is by how long it takes or the
mm,
amount of decision making. And with AI, that might take that away. And so we'll have to rethink how reimbursement happens overall. And so I'm saying that when companies are building just thinking in this manner and trying to solve a problem that they do not know or cannot really predict, it's not going to work. What they actually need to do, and all the telemedicine and RPM platforms that have done this, where they
mm,
actually built it for the clinician, for the healthcare system, made it patient friendly and easy, those are the ones that actually worked. And because theirs worked, they were able to come to the government and say, this is how we built this out. And reimbursement was built around it. And so I'm trying to basically warn everybody you want to actually do it in the reverse way, make the right product. And reimbursement can follow in the way that we do it in the US.
mm. But that's a lot of change in terms of system policy, mindset, work with different stakeholders to make that happen,
Mhm.
right? Because currently it is all bill for services. That's how system works.
Absolutely. Yes, I'm not disagreeing with that. This is just what I'm seeing as a pattern. And so that's what that particular reason was for. But I'll say there is a pathway to do this. I'm not
Hmm,
saying it just to say that. There is a pathway that this can happen. And that's what I'm referring
right.
to.
Let me ask.
For the clinician, for the healthcare system, made it patient friendly and easy. Those are the ones that actually worked. And because theirs worked, they were able to come to the government and say, this is how we built this out. And reimbursement was built around it. And so I'm trying to basically warn everybody you want to actually do it in the reverse way, make the right product. And reimbursement can follow in the way that we do it in the US.
Let me ask you a system level question.
Mhm.
Most hospitals were built for in-person care, and now some of them are retrofitting telehealth onto the systems. They're never
Yes.
designed for virtual care. So when your framework exposes these infrastructure mismatches, what does ideal integrated solution actually look like? You alluded to very briefly some time back when you were defining telehealth, but maybe you can explain that a little bit. And how do healthcare executives use your framework to evaluate whether vendors can deliver the true integration or just perpetuate platform silos?
Yeah. So, I'm going to just address the final point first. When we talk about silos, the reality is that even if you have government programs, even the one that
Mm,
you're describing in India or the one that I'm describing by CMS and Medicare,
mm,
technically they are still regionally different.
mm,
Even in France, right? They have a federal program that's federally paid
mm,
for, but even there, they have regions, and the way that things are actually practiced are a little bit different. So I'm going to say that first, because when you're actually going to build out these programs and implement them, that's actually how it's going to happen. It's not going to be at some grand scale. It's going to actually happen within these small regions, health systems. So when you're talking about retrofitting, and that's true, the
mm,
reality is you can't. It's not even a retrofit per se. It's that we now have digital tools, and so we're trying to figure out how does it fit in the system. And what I usually tell and say is it is better to have a hybrid program from the start, where the option is in person as well as telemedicine as an option, rather than trying to add on a telemedicine only option the way that we're seeing in the market that then
Hmm.
tries to integrate into a health system by maybe sending them notes. That makes it much, much harder. Sometimes that's what's
Hmm.
necessary, but it's much, much harder. So
Hmm.
generally, I'll say two. So going back to the region specific thing, you have
Hmm.
to know what you're solving for.
Hmm.
Another common example I give, so Jefferson in Philadelphia, we were in a small city. So we were a health system that was competing with four other hospital systems within that city. University of Michigan, where I had gone for a lecture to give a lecture on telemedicine, they were saying that when they were building their telemedicine program,
Hmm.
they were a tertiary hospital, academic center in the middle of nowhere. And so they had a lot of smaller hospitals sending patients to them. They had a big geographical area. I think this is
Hmm.
relevant to India too, right? The cities may have a lot of hospitals and they have geographical regions with very few, maybe one that everybody has to go to. So if
Hmm.
you're going to try and build the telemedicine program, it cannot be the
Hmm.
same. The people at the University of Michigan said, we don't need more patients. We need to serve our patients better. In Philadelphia, they
Hmm.
were obviously wanting an option to serve patients better, but they were trying to get new patients, right? And so those outcomes have to be factored in when you're trying to integrate. And so asking the question first, what is it? And then second, what is your patient population? Who's using it? Who needs it? Um, what gaps are you trying to serve? Because you can use telemedicine in so many different ways, but you're not all
Hmm.
going to have the same problems in each area. So you have to really clearly define what that problem is.
And um, you're more advising towards a hybrid kind of model. So some of the care can happen in person. For example, mental health could be a telehealth consultations, where others could be different. Is that some kind of a mix of both those care?
Yes, but I wouldn't say it's just mental health. So in the
Hmm.
ER, I think there are certain ER types of complaints, well, the ER urgent care type of complaints that can be seen over telemedicine. But
Hmm.
if they do need to come into the ER, uh,
Hmm.
we send them there. Or you have surgery patients, they can
Of
maybe do
course.
their pre-op visits with the doctor on video without having to come in. Obviously, they need to come in for the surgery, right? That's
Right.
impossible to do remotely.
Yeah, of
But
course.
this is what I
Yeah,
mean by hybrid. It's just really thinking through what are the different touch points that patients have and then figuring out where you can implement it.
got it. So now let's address the print in the room that your framework consistently exposes, which is telehealth. Telehealth was supposed to democratize healthcare access, but the data tells a very different story. Um, so here are the equity gaps that should concern every healthcare leader. And what I found researching, and this was striking. So first, economic barriers. So household earning over $75,000 have 92% broadband access, while those under $30,000 just have 57%. Below the poverty line, only 9.8% used telehealth during pandemic. Cross geography patterns show similar exclusions. So just 13% of India's e-Sanjeevani platform users are seniors, while 21% of Americans over 65 don't own smartphones. Rural adults in the US are 42% less likely to use telemedicine. And infrastructure gaps hit the most vulnerable. That is, 18% of Native American tribals lands have no internet access at all. Americans with disabilities have 26% access to full digital connectivity versus 44% for those without it. Now, Dr. Joshi, when you see these patterns in the data, what should healthcare leaders conclude? Are we accidentally building systems that widen the health disparities rather than close them?
We are building the healthcare systems that we already have. I'll say this. So when we're exposing a lot of the inequity that has been there and been part of it, but now that you have to think through digital medicine and where people are, and we now have phone records or we have these statistics about Wi-Fi and who's using them,
All right.
it becomes much more obvious what's happening. And that is a very general statement. But here's what I mean by that too, because you're talking about when, um, uh, we're talking about, let's say, Wi-Fi connectivity, right? So you're right. There are areas of the world that people don't have any Wi-Fi, which limits their ability to do video calls.
Yep.
They also probably, and this is probably true in India too, if they don't have any
Hmm.
Wi-Fi connectivity, they're likely not in a place that is near a hospital either. They probably don't have that. Maybe there's a community health center, maybe there's a healer or a doctor in the area, but that might be it, right? And so you already are seeing some of these inequities come out, and I think it's just exposing more of it. Saying that, right, is if that we are talking about implementing telemedicine, we are implementing AI potentially into a lot of these programs. What is happening is that if we're going to do that and make it a real part of the healthcare system, these
Hmm.
places which are already vulnerable are going to be missing out on that also.
Right.
And I'll tell you, but even when I started in this, it was very
Hmm.
clear for anyone, all of us there, that this was going to be a problem. But
Hmm.
when we started, nobody was using telemedicine. Nobody, they didn't know what it was. I had to explain it to anyone I met.
Hmm.
And at that time, we were really trying to figure out, what is this? How do we make quality visits? How do we even like formalize this in any way? And so we were really just starting it from scratch, but it was cash pay, and we knew that this was going to be a problem. And then, yes, it is. When you're asking about what we can do as health
Hmm.
leaders, there are quite a few things. So, and there's a company I work for that has made the commitment that they want to see patients who have Medicaid, a group that often a lot of doctors will not see, but they make it
Hmm.
priority. The percentage of all the patients that are seen on the platform are Medicaid patients. That's one example.
Hmm.
That's a small example, but things like this can make a difference. The Native American reservation that you're referring to, there are clinics up there, and there's one in Alaska that during the pandemic they started a telemedicine program there for cardiology. And because of that, they were able to lessen the amount that they needed a cardiologist to go there. It saved
Hmm.
them money, and they were actually able to treat more diseases in person, not necessarily on telemedicine, but in person because of that money saved.
Hmm.
So I would say that it's not even just a one size fits all. I feel like that's what I
Hmm.
say over and over, but we are trying to catch up. This is really what's
Hmm.
the problem. We're trying to catch up, but I haven't decided, and the data doesn't even necessarily show us. Is it because digital medicine is making it worse, or is it because this was already a bigger problem, a big problem, a growing problem, and this is just exposing it?
This probably existed with or without digital health systems. It is just that the access for so many people just not there because of the way they operate, the way the technology has not been able to go there for so many different reasons. It doesn't have to do with the telemedicine, but if telemedicine or telehealth have to be inclusive, then some of those gaps probably will have to be addressed.
They will have to be. And in general, we'll have to
Right.
figure out how health systems of the future and the clinical workforce of the future, how are they going to handle this? Because as you know, nothing about health and medicine is isolated. We can talk about
Yep.
climate change. We can talk about the way that rural areas are losing access to even more healthcare. We can talk about tech and how, if it's part not even just of healthcare, but of life itself, how are you making sure to include everybody in it? Because that's widening gaps in income, not just in health, right? And so these are all play into how our healthcare and how our health is, what we call the social determinants of health. And I will say that one good thing is that there is a list of what the social determinants of health is, and access to
Hmm.
Wi-Fi and connectivity was actually added to that list for that reason.
Yeah. So there is a persistent myth that handing out smartphones and broadband automatically creates equity, but it doesn't. Because recently you wrote about South Korea's West Sea Island. It caught my attention, where elderly patients need phone consultations and local hubs with real people helping them, remarkably similar to India's e-Sanjeevani, reaching out only 13% of seniors. So, what consistently creates these exclusions, and how do we move past this access equal equity mindset? It is not just the
Absolutely.
US, India. It looks like it's a pattern that we are seeing in different countries. And you quoted South Korea's West Island too.
Yeah. So The reason I even brought that up is because we've seen this problem before. And it's not just the US, it's not just Korea. I have read this story in multiple countries as we're doing that, India as well. I did
Mm.
specifically. When you look at the people in the senior population, um, a lot of them a lot of them want to see their doctor in person, but a lot of them
Yeah.
also just not. They don't necessarily have a smartphone. They don't necessarily want to get onto telemedicine. But what they can do because they're used to it is phone calls. And so that's why I always make a point of saying that telemedicine includes phone calls.
Yeah.
So what they've done, and at least they've done in the U.S., that they have included it as part of that, and it's paid for. And if you look at the story in South Korea, the doctor there was saying you need to include this because our
Mm.
patients need it. They need this ability to just be on phone call consultation so that we can actually access care to them. And this brings up the point just about how do we deal with populations who are elderly or senior and they don't maybe want to, or they are not used to this. And maybe, they're just not equipped to do this. And of course, people can say you can have a family member do it, you can have somebody help you. Yes, of course, but not everybody is going to be able to do that. So you have to figure out what is a solution. And often the solution is phone calls. We've all used for, I assume, our entire lives. Yeah.
Right. Have you seen some of the healthcare platform that get designed, got inclusions right from the design phase rather than trying to retrofit it later? Like, for example, you're saying feature phone use or even phone rather than the smartphone. Have you seen any healthcare platforms do that?
Have it right from the start. I don't know if I can answer that mainly because a lot of the time, by the time I see a platform, we are using it, or I'm going to implement it, or I'm evaluating it for you. So I won't always see all of the different parts of it. But when I
Mm.
was referencing some of the platforms that have done it well, often
Mm.
what it is, and all I was referring to is that I will see a pitch and I'll see a demo and it out, understands the way that the clinician pathway works,
Mm.
uh, the barriers, the challenges, as well as also the patient side. And you can't forget that because if you don't try it from the patient side, the patients are just going to stop using it if they can't use it well. And so I can't say that I would say that anyone probably did it right immediately. Most
Mm.
platforms obviously update and change things, and
Mm.
I've seen that more often. But I don't know if I can say that anybody started out.
Right. Let me ask you this. If you could change one thing about how the industry approach inclusions, and that's true for all countries put together, it doesn't matter, India, US, what would that be?
You can't ignore it. That's really it. You can't ignore it. You can't ignore the data. You have to look at where the problems are and don't be afraid to address it, even if it is easier to do it elsewhere. And it's not that I think that people are not trying to do so, but the barriers are less, let's say in cities, for example, because it's easier for the Wi Fi, the connectivity in this example that we're using. And so the barrier is less and people just have it. But it doesn't mean that it shouldn't be tried in other places. And, I have
Hmm.
heard of hospital systems building out tech forward hospitals in India to try to solve this problem in rural areas. Sometimes they're from foundations, etc., that are doing this to solve that problem in those regions. And so I think it is being recognized. It is just a harder thing to do. It's just harder.
Would you therefore advise people to have a look at all these five pillars in the beginning? Patient success, clinician success, technology success, and compliance success at the design stage, or reevaluate them whether their platforms are really aligning to them?
I'd say both. It's never a bad idea to plan well, right? So you take a look and say, what do I need to do to make sure this is going to work or set us up for success for the best that we can. But of course, part of the framework is not just planning; it's also can be done simultaneously as you're building. And then, of course, for ones that are already running, the second question is how do you scale it and how do you make
Yeah.
sure that the outcomes that you're trying to achieve are actually happening? And it's a great way to take a step and say, all right, am I hitting them? This was the goal of this project, or maybe the goals have changed because like I was giving in the teletriage example, uh, one of the problems you're trying to solve, we
Hmm.
couldn't. So that had to be handled in a different. And so I would say that, of course, I think it's always like that. And I'll use this example, all right? And all the
Hmm.
doctors who are listening, you're going to know this, or actually anybody who practices, all
Hmm.
clinicians, it's true. When you take your oaths, one of the oaths and things that we promise is to learn
Hmm.
forever. And this is no different, right? So it's built into the way we work. We learn forever, we change forever, we reiterate all the time what we're doing. And so it's no different when you're building a healthcare system and a program for patients. You have to reiterate, you have to look at it again, because medicine is never finished, healthcare is never finished.
What I'm taking away is that equity can't be an afterthought. It has to be built into the system, and the framework supports it from the day one. And that takes us to the next question, that what can different countries and health system learn from each other's approaches? So let's take a moment to zoom out to the global perspective, because building truly effective system means learning from what's working worldwide. So each major healthcare system was developed with some distinct strengths in telehealth, but research consistently shows none has figured out how to combine scale, equity, quality simultaneously. At least in my research, I haven't been able to. India's approach, for example, this is a massive government led scale, no doubt, standardized processes, national reach. US taken a different approach, market innovation with complex reimbursement systems, patient centered design. European model is different regulatory frameworks, privacy standards, integrated care coordination. So, Dr. Joshi, from your cross geography consulting experience, what specific elements should each of these approaches be borrowing from each other's? And if you were advising a health ministry or major health systems, what would you tell them to adopt from other countries' success?
So I think when you think about the global scale and the way that healthcare system works, what is interesting is that the solutions, like you mentioned, are going to be different, but some of the problems are actually the same. They may not be to the same scale, they may not be in the exact same way, but many of the general problems and the challenges that we have in healthcare are going to be the same. So one is, how do you actually give every person in your population access to healthcare, right? That's going to be a question across the board. Some people have the problem that even in a city, people can't reach a certain destination due to bad transportation or traffic, right? And in other places, it could be rural and geographical, uh, for example. So that can be part of it. It can be that there are mountains. So there's going to be that aspect, right? And so if you think of it in this big problem, that's one thing that many challenges. Second, we're seeing that, we have the same diseases, these chronic diseases are growing because as the population is aging almost across the world, we're seeing a different change in the types of diseases we're finding. And so some of the ways that we use digital medicine for those can be shared as well. Like, what are people doing for that? How are they actually solving it? Because we use a lot of the same medicines, and so it would not be any different to try some of the same programs. And the second, the third, like we were talking about, how do you deal with some of these inequities, the social determinants of health, the changes from climate that are creating places and are affecting healthcare dramatically? How do you fix some of those? How do wars, disasters, how do they impact health, and how can we actually help one another, knowing what we might have done in the same situation or in simultaneous situations? So I'll just say that in general, a lot of these problems tend to be the same. And so when you're trying to learn from each other, right? So when you bring up the South Korea story, it's one that the US already had to face, and our solution was paying for phone calls. And, that's the story. And what I was trying to bring up is they figured out the same thing and they're asking for that same thing. Uh, and, they didn't necessarily need to look at us to do it. But some of those questions, if we just research around the world,
Hmm.
we can find maybe what did somebody else do differently that worked. When I think of the EU and I think
Hmm.
of the way that they're trying to regulate I think that we learn from it. They're trying to do it in a very safe manner. It's not perfect, but they're really trying to think it through before they
Hmm.
build and then just release it into the market in healthcare. I find that really is a comforting thing. So I don't think, I think with the advent of the internet and the ability to share and to
Hmm.
have these conversations across the globe, like even you and I are having, we
Hmm.
find and we're going to be able to talk about some of the barriers and challenges we have and see what other people have done. But
Hmm.
I would talk about it in a broad sense, right? Look at the problem, not necessarily the scale, but sometimes a solution, even if it's a small solution, can
Yeah,
work its.
makes sense. You have consulted with digital health startups across multiple countries too, as I understand. What's one strategic mistakes you see founders make repeatedly when building telehealth solutions? Something that undermines the outcomes regardless of which market they operate in.
Yeah, and I'll say this for all of digital health because I don't do just telemedicine. I also see AI companies, RPM companies.
Hmm,
It's not speaking to clinicians early enough. So building a product that user cannot use. You would think that we had moved past this and it would be
hmm,
obvious, but I have seen so many times that they are not recognizing the process that clinicians actually go through. They're building it without their input. They're building
hmm,
it with input from somebody who is actually not doing the exact thing that their product is supposed to solve. Meaning, for example, if there was somebody coming into the ER saying, "Oh, we're going to fix this problem of in Philadelphia, for example, that only a rural hospital would have," that's not very helpful for our hospital.
hmm,
So, just having like the wrong set of advisors. And I understand it because often it can be expensive to hire
hmm,
conditions for that type of input. And I tell people you can do it fractional, you can have advisors. There's ways to do it, but
hmm.
this should not be happening. It should really have the input of the people who have to use it, and the workforce is going to use it.
Got it. Okay. In your recent article, you argue that we should ask, does this actually improve care? Instead of how do we get paid for this? So, looking at the telehealth explosions during COVID, how much of what we built globally that time was driven by wrong questions, and what are we seeing as a result?
The pandemic, though, is a very isolated, unique case, mainly because as an emergency, everybody had to do and uptake things quickly. There was really no time to evaluate in depth. However, because of that, a
But we
lot of
move very fast, though, right? We move
we
very
did. What
fast.
I'm saying, because you're asking about the telemedicine platform. So what I'm trying to
Hmm,
say is, or what I'm saying is that those platforms already existed and they had been vetted already by clinicians. So people had to
hmm,
use ones that were already existing and working. And so
hmm,
for that reason, it probably was a little bit better than it would
hmm,
have been had everyone just have to build something from scratch. Because these things already existed, clinicians were using them. We had a couple of options that we could have used in the US that were private and secure, and they were built for doctors, for clinicians. And so I do find that it's an isolated case. And so when
hmm,
you're referring to these care pathways and what I'm referring to when talking to clinicians,
hmm,
I'm talking about when you're designing or when you're piloting or when you're using it, right? And the pilot can actually uncover maybe some of these problems, but this is what you have to do before you scale it. And I also, when I'm talking to health systems or even
hmm,
governments, if you're going to buy a product, have someone
hmm.
try it out or pilot it. So see if it works because you definitely do not want to invest or get stuck in a 3-year contract with
Hmm.
something that does not work for what you're trying to do.
So, one more thing is we are seeing some big move towards healthcare interoperability. Like in India, we have ONDC, which is Open Network Digital Commerce. That's a project of connecting different systems for billion people because India, everything has to be done to scale. So for healthcare leaders trying to build integrated telehealth program, why making these systems talk to each other so critical for actual patient care? So,
Of course. So we'll use two common examples, right? Ordering labs and prescribing medications that patients need. And for labs, you want to be able to do it easily so the patient can go and get it, and then I can get the results in a timely manner and evaluate them, right? Otherwise, there's what's the point of getting it if they're lost? Something could happen to the patient that I don't recognize. And there's a lot of risks involved. So you want to be able to see it. And then second, of course, if you have a prescription, you want to be able to make sure that the patient gets it, that the pharmacy gets it, and that the patient can actually take the medication at the time that they're supposed to. So you want it to be seamless in that manner, right? This is all obvious, but what I'm trying to say is sometimes that solution may not be digital based on the market you're in. Okay, let's use India as an example, right? Everybody knows that the couriers that like Mumbai, for example, I was just recently there in March. The couriers around there get things to people in record times. It's like incredible,
Hmm.
right? They did a whole study about this. And when I think about when you're talking about medications, for example, if there isn't a way to make it interoperable at the moment, there is already this system in place that technically, if the pharmacy can get it and there is like a company in between or some way that they use a courier system to actually get the medications to patients, maybe that's going to be a solution for a problem that interoperability that maybe is unique, right? Because they have that solution. And it may not be a digital solution. Would it be easier if you could have it in a digital solution? Yes. But we were also just talking that there are a number of people who don't have that option or don't
Yeah.
like that option. And so you need to be able to create it in a way that's hybrid. And that's why hybrid is important, because you need to be able to do it easily. But the interoperability is going to be even more important as we think
Hmm.
about how we're going to use AI, because you
Hmm.
cannot have data silos
Right.
if you are going to actually put data into an LLM and then dictate clinical decisions or even
Hmm.
just the way you're triaging, you cannot do it with siloed data. And so this also becomes
Absolutely.
really important. You can't have the example I give, you need the list of medications and you need their lab work to actually understand where that patient is coming from. And so this is going to be another second reason that we're going to need it. And this actually is much more complicated. And so when talking about the framework, when I was reframing it for using AI, I added two
Hmm.
different things because AI is going to make this much more
So
difficult.
this framework that you developed, when was it actually developed?
It was in the
Which
book, so
year?
we probably refined it in 2023.
Will there be a separate additions or or updates
Yes.
to the framework in the books? And if you're going to release it, any new updates, maybe you can tell the audience when is that release going to come from.
Absolutely. This is probably not necessarily going to be in the book form. I don't know if I have plans to update or we have plans to update the book. But this is just thinking through as I'm adding AI to what I've been working on in consulting, et cetera. It's how do I actually add this in a way? And so the two things that are added, I'm happy to share it, is data intelligence, similar to what we were just talking about, interoperability and getting the right data. And then seventh is infrastructure. Because if you're thinking, and this infrastructure is actually the problem with what we're describing in this interoperability, it's not the interoperability that's a problem, it's really the infrastructure needed to actually build it out so that AI can be used in a safe manner. Because otherwise, it's really just not safe. We're getting
Correct.
data and if we're talking about India, for example, I will tell you so as an ER doctor, we don't always have the right data for a certain population. So the South, and it's going to be no surprise to any of the Indians listening, but heart disease is it's very high in India, right, in the South Asian
Yeah.
population. And so we kind of know it in the US, we learn it,
Hmm.
but we don't really have the great data on it because we're not getting this data from India because for whatever reason, we don't really share research in this manner, but we tend
Hmm.
to know it. So we actually put in a different risk stratification, but we don't do it in any formalized manner. So if you're taking about this data and the intelligence you use, we should be able to get some of that data from around the world to be able to apply to populations if there's a risk factor like this, right? So I think about it in such a broad sense of how we need to be smart about the next step. And so when people try to push through AI quickly, as like, there's a lot of things that make it very difficult to do that, and we can't do it the same way as we did telemedicine, even within virtual care.
All right. So we explored the frameworks, the equity gaps, the global approaches. Now, let me end with some fundamental questions that will define the next decade of virtual care. So, Dr. Joshi, let's forget about technology metrics, adoption rates, or platform features for a moment. From the perspective of a patient who needs care, a clinician trying to provide it, and health system trying to serve their community, what does actual success in telehealth look like? And is there a moment in your work where you thought, yes, this is what we are building towards?
So just in general, anytime an access issue and somebody got care that normally would not get care, that is always a win as an individual thought process. But when I think about what we're going to be looking at in 10 years, first of all, the word tele is going to go away. It's just going to be part of healthcare.
Hmm.
And What I would like to see, aside from just making better healthcare accessible, thinking through these connectivity and how we use and are accessing healthcare in general, is I really want to see, and what I hope we're building, is making and giving more power to individuals over their healthcare. They have more information, they have more data about themselves, so they can make decisions knowing and having real data. And then when they check in with their doctor, clinician, or whoever they need to see, they actually feel like they have some ability to take care of themselves, right? We have a big disconnect in health literacy and how we even are able to speak or information. And I would like to see that solved just because we're not going to be able to do it in our hands.
So based on everything that we discussed, the framework, the insights, the billing-driven design problems, the equity gaps, if we had to identify top 3 systemic changes that would actually fix this, what would those be?
Better connectivity is one, right? Just if you're talking about digital medicine specifically, I am not giving 3 answers for the healthcare system in general. That is very complicated. So that's one. Second is really understanding and figuring out how we're going to get better access to care everywhere, right? So whether it's rural, whether it's hospital systems that maybe need it within even a city, right? Because they don't always have the same standardization, is making sure that there is that access. And then 3, standardization of data. And I'd say also standardization of how we're practicing and what we're offering.
Got it. Is there anything else that we haven't covered, but would you like to say something about?
I would just encourage everybody, really make sure that what your product is building is actually going to help patients in the end and be useful for clinicians. Because I think that is such a simple thing to say, but I cannot say it over and over and over enough. Healthcare in general, and medicine in general, is complicated. It's a applied science. It is always changing, and that's okay. But if you're going to join us and be part of that healthcare changes, you're going to have to be okay with that.
Right. Thank you. And so when I reflected on it over the last 1 month that I've been trying to understand this space a little bit and now got some of this question answered, here is what I take away is that access doesn't always equal to equity, usage does not equal clinical value, scale does not equal success. The real success means that the right person got safe, effective care that actually improved their health, delivered in a way that respects their circumstances, culture, and capabilities. And that's the standard we have to build towards. And Dr. Joshi's framework gives us the tools to measure whether we are getting there. And Dr. Joshi, thank you for sharing your insight and expertise. And this conversation has been invaluable. And I'm sure those who are listening, you're taking away as well. And anyone who is serious about healthcare outcomes. So thank you, Dr. Joshi.
Thank you.
And to everyone listening, if this conversation changed how you think about the virtual care effectiveness, then please do subscribe. We are the only podcast giving you this level of analytical insights on healthcare outcomes, not just healthcare technology. Share this episode with someone building, funding, implementing telehealth. They need to hear this framework approach. Let us know what's your definition of telehealth success. Your insights shape our future analysis. Coming up next on The Spark and the Forge, Mukti Bosco, founder of Healing Field Foundation, on how rural women are redesigning care, delivery, and what policymakers need to understand about grassroots healthcare innovation. Until next time, keep measuring outcomes, not just the outputs. I'm Subrata Kar. Thanks for listening. India, even if I look at this national platform, percent of specialist consultations go to the wrong specialty. When you see this kind of pattern, high volume but questionable quality, what could be the potential root causes?
Yeah, I'll say you're talking about a large scale problem. numbers, but this is not an uncommon.
Are we accidentally building systems that widen the health disparities rather than close them?
We are building the healthcare systems that we already have. We're exposing a lot of the inequity that has been there and been part of it. But now that you have to think through digital medicine and where people are,
All right.
it's much more obvious what's happening.